Hymns House, episode 43. My name is Jonathan Stern. I'm here as always with Patrick Lester, who goes by the name Bayside in the Hymns House Discord. Today we're joined by one of the world's foremost experts on peptides, Dr. William Seeds. Dr. Seeds is a board-certified orthopedic surgeon, the founder of Seeds Scientific Research and Performance, and is widely regarded as a pioneer in peptide therapy and peptide education. We wanted to bring Dr. Seeds on the show because over the last couple years, peptides have become one of the most hyped and least understood frontiers in all of medicine. In certain corners of the internet, peptides are being talked about as if they are magical. However, if you talk to other people, they are all hype, no substance, and by the way, totally illegal. So for today's episode, I'd like to set forth two main objectives. Number one, I want to understand how important peptides actually are for the future of medicine. And number two, I want to help HIMSS investors make sense of the legal landscape and explore how HIMSS might legally enter and participate in this market. Dr. Seeds, welcome to HIMSS House.
Pleasure to be here. Thank you. Thanks for having me.
So I gave a brief overview of your background just now, but I'd love to hear it from you. How did you first get into peptides, and what drew you to this field many years ago?
Really, I lost my father at a young age, where we were jogging together, and it was a pretty bad situation where he was my best friend. We did all these things together. A guy I looked up to, he was my mentor and my father at the same time. And he dropped in front of me while we were running, and I couldn't save him. And it was a pretty traumatic experience at the time. And, it's one of those times when you're all of a sudden you had to grow up really quickly. And it just sent me into this path of wanting to know what happened, because my father, I felt, was in good shape. I thought he was doing all the right things. And so it just kind of directed.
How old were you and how old was he at the time?
He was 45 he was 40. And I was 16 going on 17. And I just turned 17, I believe. And we just had a great relationship, and, he was the one who got me. I was very sports oriented, but, when that happened, it opened this door for me I needed to know what happened and why. And so I just started on this journey of, even though I was in school, I was a finance and accounting major. I spent all my time in the library focusing on what I wanted to learn about the cell. But I built basically a reservoir of, I think, over 4 years of incredible information about cellular metabolism and about the immune function of the cell. And then I thought to myself, gosh, maybe I should go to medical school, and because maybe I can do something with this, because I really think this knowledge base can be helpful. And then I got into medical school, and then I could see all these things of where I was in a position of, knowing what the knowledge base I had, I didn't realize how much it was helpful. And then I got into orthopedics, and it was very interesting as I started really looking at that, and I had this knowledge base. I said, my gosh, there's things that we can start doing right now that I could optimize cell function and make my surgeries better. Well, as I started doing that, I started keeping people out of surgery, and I started optimizing the environment for the joint that despite, there were things that we just didn't know at the time that I was actually learning, that I think changes the whole scope of how we look at things from a molecular perspective. And so it's more like molecular logic was what drew me into this place, not the pharmacologic effects, but peptides. They help the body do what it's supposed to do, unless there are things that are affecting it, comorbidities, disease, age, stressors, Well, you have to take those things into account. And with peptides as cell signaling agents that are known by the body, you can, and I'm talking in general terms, trying to not get it too complicated.
Yeah, so maybe before we go into all of that, many of our viewers are investors. Some of them are biologically or scientifically minded, but I do think it would be helpful to start with something like a Peptides 101. So just briefly, this could be a quick segment. What are peptides? And I am curious as well, why are they sometimes referred to as miracle or magical drugs? But let's start with like a 101.
Okay, so great question, and thanks for keeping me boxed in the right place here. Peptides, they're short chains of amino acids. They're amino acids that are bonded by a peptide bond. And they're essentially like fragments of proteins. And they act as messengers in the body. Just think of them as messengers that the body's familiar with. They regulate metabolism, they regulate immunity, they regulate brain function, they regulate tissue healing, tissue repair. I mean, so from that standpoint, it's pretty straightforward. They're messengers and signaling agents that are affected by all of those things I've said and also control those things. And so I think they're called miracle drugs from my perspective because they have great specificity and they have very low toxicity profiles. So they're remarkable when you compare that to a pharmaceutical, and that's because they're natural to the body. The body is familiar with the signaling, knows what to do with it. So you get very specific. You work in very specific areas with these to influence metabolism, immunity, or so forth. And so I think they don't shut down pathways like pharmaceuticals do. They basically restore balance. You can think of it like that. And I'd caution you to reference them as magical. They're not magic. They're tools that we use. They're very specific tools that we can use when we combine them with nutrition and exercise and sleep and cellular optimization. Then that's when you see miraculous changes. I mean, when you know how to use these in conjunction as a tool with other things that we're trying to optimize. So maybe that's a better perspective of looking at that word.
Helpful. And I definitely use magical probably twice, mostly repeating what I see online. But helpful to have that foundation. And with that, I'll turn it over to Bayside with a couple more specific questions.
Sure. I think we've heard some general overviews, which are helpful, but I want to get into some specific examples. So let me start with something that I think our audience knows already. So our audience has heard a lot about GLP-1s lately, probably more than they would have cared to have heard. But as the audience probably knows, the P in GLP-1s is a reference to peptides. And that's great. We're not really talking about that, though, here. We're really interested in what else is potentially out there. How else could peptides be used? What else should be on our radar? I guess another way of saying this is, what are some of the other potential success stories that you've seen from people taking peptides?
Yeah, so that's a great question. And I don't want to, there's no doubt that the GLP-1s have kind of stolen the spotlight. But the peptide universe is much larger. And I want to say, I just finished a book on GLP-1s. I've been teaching about GLP-1s for over the last 10 years. And I will say, though, that the GLP-1s have incredible polypharmacy or pleiotropic pathways, if you want to call them, meaning we've known about these GLP-1s for a long time as far as not just being very specific to one molecular pathway. That's why they've been so incredible. We look at them as what they can do in their aspect of working on metabolism. Weight loss is a side effect to improve metabolism and cell efficiency. And there are many other pathways that these GLP-1s work that you'll continue to see this data keep coming out about where you're going to see it used in cancer, you're going to see it used in neurodegenerative disease, you're going to see it used in for improved bone density, for improved immune function. You're going to see a lot of things coming with these GLP-1s, which the research has been there. It's just people have really not paid attention to it. So I'll leave it at that. I mean, we have peptides for healing, for inflammation. We have peptides for immune modulation and tissue repair. We have peptides for improving the growth hormone axis, building muscle, improving lean tissue mass. I mean, we do things when we use these GLP-1s, you can use these GHRHs and GHRPs that are specific growth hormone axis muscle preservation peptides that you don't even get into the issues of losing muscle mass. You help people maintain and build while you're losing weight. There's mitochondrial rescue peptides, which is really where the future is headed. And then there's barrier defense peptides in the gut. I mean, I could go on and on. There's probably
in terms of like the most popular that should be on our radar. I mean, I've heard of a few.
Oh, like, you mean like name specific?
Names like Simorlin, I've heard of. I've heard of BPC, right?
There's BPC 157, there's L37, there's KPV, there's Larazotide, those are gut peptides. There's thymosin alpha 1, thymosin beta 4, there's thymosin TV4 fragment, there's GHRHs and GHRPs like tesamorelin, simorelin, CJC 1295, MOD 1.
Make sure you're taking good notes on this out there.
There's
talking to the audience.
There's hexarelin, there's ipamorelin, that's GHRP2, GHRP6. There's MOD-SC, there's SS31. I mean,
I'm feeling you can keep going.
Fantastic. Yeah, this is good.
Let me ask another question.
I'm happy we got those out there. Yeah, keep going, Patrick.
So what's interesting is you just ran through what sounded like 10 to 20 different molecules potentially that are out there. What's also interesting to me as a layperson is it seems like every time I turn around, there's some new study out there showing that semaglutide is good for yet another health condition that's not weight loss. So it's not just that there are multiple different versions of peptides that can do different things. The same peptides apparently can do multiple different things, which is interesting. And it kind of fits with what you said a second ago. So I think we'll come back a little bit later in the interview with some questions about the future. So I'm going to shift a little to more of a present day issue, which as we think ahead in terms of research and development, would you say the main obstacle to further development is on the legal or regulatory side, or is it on the technical scientific side?
Oh my gosh, that's what I call a no-brainer. I mean, the science is accelerating, but the legal and regulatory issues are significant. I mean, they're barriers. It's not a scientific barrier. We have a lot of promising peptides that are just sitting in limbo because they don't fit into this pharmaceutical approval pipeline. Mm-hmm. They're geared toward, the pharmaceutical pipeline is geared towards patented molecules that have single targets. Well, a lot of these peptides they don't fit in that model. They have multiple targets, right. and they're natural, and some of them can't be patented. So it's an area that they just don't have this worked out. And I mean, we have thousands of signaling peptides that we haven't mapped out yet. I mean, we have this thing called the dark peptidome that we only know about 5% of these peptides right now in our body that we know of that are significant and are effective. But think of the 95% we don't know about, that because we just can't, because they're small enough that we can't see them in all these proteomics, because proteomics only go to about 50 amino acids, and then below that are where we're talking about a lot of the most effective peptides that we have, and we're not even looking for these things yet. So it's going to be incredible when we get that aligned, and that's a place that I'm very focused on right now. I'm focused on really the educating everyone and getting the maybe more of the a process of where we do more evidence-based studies, clinical studies that can accelerate this process. But here's the other side of this. I mean, we have a lot of great data and mechanistic data and molecular logic data that tells us a lot about these peptides and tells us their safety profiles and their toxicity profiles that you can't ignore. And we should be able to find ways to be able to fast track that and make this process better, because I'm going to tell you this, it's happening outside of the US and it's happening fast. And the US needs to get it together, or else we're going to lose this dominance. Even though we have the dominance in the GLP-1 world, the world's much bigger outside of the GLP-1s. And that's changing as we speak.
So we've talked a lot about the benefits of peptides, but not everyone is sold on peptides. And so I want to just chat briefly about why. There was an article that I found in preparation for this by one of the world's most respected cardiologists, Eric Topol. He wrote this long article, maybe you saw it, criticizing what he called the peptide craze. He called it overhyped, dangerous, lacking in robust clinical evidence. And you just mentioned clinical evidence, so I want to ask about that. Topol's main argument is that there simply aren't enough high-quality scientific studies supporting the safety and efficacy of peptides. So, question to you is, are there studies that he is overlooking? And if not, what would you say the clinical or scientific case for peptides is in the absence of large-scale randomized controlled trials?
So Dr. Topol, he's not wrong in he's right about the hype that can be excessive, right? But that's with anything. Large-scale randomized controlled studies are limited, but he's overlooking the depth of the preclinical data, the smaller clinical trials, and the decades of European and Asian experiences with these peptides. And that is something that you can't ignore. And we have high mechanistic quality studies.
And what does that mean, mechanistic? For
most of these peptides we're discussing, it's the same process, whether it's in a dog, a monkey, a human. You can't ignore mechanisms and molecular pathways. It's like how you can make predictions about how something is going to work, and also why you can say the safety profiles are typically excellent when you compare them to traditional drugs. There are mechanistic studies on all of these peptides for the most part. I think from Eric's perspective, I think, in all due respect, I think you only know what you know. And that's no disrespect to him, but even in his own specialty, there are already specific and promising peptides being made for specifically in cardiology for enhancing contractility of the heart, lowering blood pressure, working as combinations. The Mayo Clinic has finished, they're in phase 3 trials for peptide that is a diuretic, natriuretic, and antifibrotic. I mean, managing heart failure. We have a peptide coming out that's a ZP123 for controlling atrial conduction, like stopping AFib, arrhythmic therapies like that. That's out there. These are things that are all very close to being utilized in his field. So peptides are exploding in cardiology. So all due respect to Eric, you need to look in your own field. And I think that's the take home message is, holy smokes, what's happening out there? And that's why I think, with what you're going to see and we've got it. Look at what we've gotten wrong in the past with these single, looking for one treatment with one drug, that we do these clinical trials for that really, half of them end up being what they're supposed to be. Half of them end up, a third of them end up being never what they're proposed to be. And the real way I see the future is evidence-based, clinical evidence-based studies that are going to push all of this forward. I mean, utilizing these peptides and having the privilege to work with people and see these changes with people that, have had serious problems with COVID fatigue, autoimmune diseases, post-cancer fatigue, all of these things that we've been able to participate and change their lives. It's amazing. It's incredible. And there's no denying that. And I think that's why you're continuing to see this push forward. It's
just a quick follow-up question, because it's clear that the drugs are extremely powerful. The potential is massive, but it does sound like there are fewer randomized controlled trials than with other drugs, with legacy pharmaceuticals. And if that is the case, why is it that peptides have fewer randomized controlled trials that we have to go off of?
It's what I said before, because there's no IP in it. These are natural peptides that you can't, so let me explain some differences. These are natural peptides that you can't patent. So if there's no IP, you're not going to get anybody investing $500 million into all these studies to get things done, to get this thing to be utilized. It's not going to happen. But what you are seeing now are the focus of Big Pharma is going after these peptides, where they're taking the peptide and they're looking at analogs of how they can change that peptide a little bit to make it maybe last longer in the blood system, or to deliver, to work better in a harsh environment like the stomach, or if they can alter that peptide from its natural state a little bit, well, they can patent that peptide, and that's huge money. So there's this cutoff point of where the problem is we've got these peptides that are the natural peptides that are great, but no one's going to spend the money. And that's why that's why the clinical evidence type of papers need to be done. And I'm going to tell you that I'm fortunate enough to be involved in a group of people here in the US and outside of the US that are already ready to go with that. And that's academic institutions here in the US that are now seeing the importance of this field and its implications it's going to have in medicine in the future. We're going to finally get to do these studies to unequivocally show the clinical evidence that needs to be there to validate what people are questioning. But that is, the people that are in this space and that truly understand cellular medicine and molecular pathways, high quality mechanistic studies, which we have plenty of, are very representative of all of these peptides. And that's the beauty of this, because if we see those mechanistic studies, we know that the clinical study is going to follow. And that's awesome. That's how it should be. And that's where you're going to see more. That's where all the AI and deep learning is going to really get significantly involved in this area from many aspects. But I'm jumping ahead again, I guess.
No, let's call it there for what we'll call segment one. I said I had two objectives. Objective number one is to establish some sort of medical background. Objective number two is to dive into how hims and hers might enter the market legally. And so to fulfill objective number two, we need to talk about the legal and regulatory framework surrounding peptides. I want to say first, we had a fairly prominent doctor, biotech investor, at least prominent on Twitter, on the Hims House podcast about a month ago. He was extremely bearish on peptides, bearish on the technology, as well as on the opportunity for Hims, primarily because, according to him, peptides are illegal. And so I want to ask you, is that a full truth, a half truth, and is there any additional color you can add so that we could all properly understand the legal landscape for peptides?
Well, okay. There's many moving parts here, and I'd say it's a half truth. How about let me start with that. Number one, we have to realize there are many peptides that are FDA approved out there. Not just the GLP-1s, there are calcitonin, parathyroid, there's other weight loss peptides. There are peptides that are out there that are FDA approved. So you can't ignore that part. I think the issue is getting caught up in this compounding pharmacy issue. I think number one, a compounding pharmacy, everybody thinks that anything a compounding pharmacy makes is FDA approved. Nothing a compounding pharmacy makes is FDA approved. Compounding pharmacies don't make FDA approved drugs. They make FDA allowed exceptions. And that's why they're in their space, because they're more patient specific. And that's where the whole argument is about what compounding pharmacies do. They're patient, like a 503A compounding pharmacy is a patient specific prescription that is focused on prescribing like peptides that are off label. They're not FDA approved, but if depending on what list they're on, if they're on a 503A1 list, then they can be compounded under the discretion of the physician, and that's an FDA exception. If they're on the 503A category 3, that doesn't have and they're being evaluated actually under the category 1. If they're category 2, that's where they don't have the safety data, and that's where the FDA doesn't like that being compounded. And then if they're category 3, they just don't have the clinic or the data that's needed yet that the FDA frowns upon compounding pharmacies kind of make their decisions right now whether they're going to compound that type of if that's a peptide in that category or not. So there are a lot of changing issues there, and I will tell you that there was just the end of July here, a senator from Alabama, that Tommy Tuberville,
the former coach of the Auburn Tigers, Tuberville.
Yeah, Tuberville. Yeah, he actually sent a letter that you can get. I think you can find it online. That was right to Secretary Kennedy, focusing exactly on this and making a plea for him to get involved, to get all of these all these peptides bulk listed, and so he could just sign off on this process and get this going, so we don't have these issues anymore and how things turned up. And that is actually, that's one of many that are, I think, working from the congressional side to change this whole regulation process right now the use of peptides, because that's already happening in other countries where they're actually making exceptions for the use of peptides as we develop the ability, right, to get set up to do these evidence-based studies, which need to be done, absolutely need to be done. But we also have, that you've got to have the ability to utilize these peptides in a way that I think people aren't working in gray areas. Like the GLP-1s, for instance, they made all this trouble in complaining and saying that compounding pharmacies can't do GLP-1s. Well, that's not true. That follows actually, there was the shortage and they could do that. Then the shortage rule went out. But if we have a specific clinical difference of why we want to use a peptide like a GLP-1 because of how we dose them, and we don't want to use the standardization that the commercial peptide recommendations are, well, we have every right to use that, and it doesn't have to be altered. It doesn't have to have B6 or B12. All it has to have is a clinical difference significance that we write in our prescription and we write in the chart, and we can utilize that GLP-1 because we use it we use them correctly. This is something we've been talking about and teaching for over 10 years, and how to use these peptides. And specifically when we got to these peptides that are once a week, that started out with the Ozempic and so forth, of where titrating these peptides in a tailored dosing is very, very important. It's because if you look statistically what's happened with the GLP-1s and using them like the clinical dosing says for the commercial peptides, you've got a maybe 35% retention rate in less than a year. Well, I'll tell you that anybody that's appropriately trained in how to use these GLP-1s, the retention rate's over 90% in a year if you use them correctly in using the smaller doses, titrating those doses specific to the patient. And that's where the logic makes sense. I mean, these are significantly powerful signaling agents that you really need to know how to use these, and you need to know what else you can do to empower that peptide to do its job in other ways.
Let's get into that. I want to have some specific questions. I just want to kind of rattle off at you, and sure. Some of them might be a little longer, but let's get some quick answers if we can.
Sure.
So a really quick, immediate question.
Yeah.
Other than GLP-1s, let's put those aside.
Yeah.
What other peptides could HIMSS legally sell today?
Today, they could get into the cosmetic side with a very, very popular GHKCU peptide. Mm-hmm. That is the one peptide that has made a significant difference in the cosmetic world, and it can be utilized with many other smaller molecules.
We don't need to get into super details because we're trying to do this quickly. Are there other quick ones?
Yeah. The vasoactive intestinal peptide, which is used for the gut, used for the brain.
Okay. And just to be clear, these are things that HIMSS can legally market and sell even if they're not FDA approved.
Correct, because they're FDA allowed exceptions because they're on the category 1 bulk list that is allowed.
All Correct. Right. Another quick question, although this one could be long.
Real quickly, because Sean Norian mentioned this one. Sermorelin. What about that?
Yes, Sermorelin is yes. It's also illegal.
HIMSS could do some more. I think there's a company called Eden that's selling that one now.
Yes, Sermorelin Sermorelin's been around for 20 years. So it's been legal. It was looked at a long time ago used for another way to work on growth, stunning of growth in young children, and another thought to be utilized in that fashion. But it's a legal peptide, yes.
Okay, a few other quick ones. I know we're kind of rattling them off, but we have some other deeper questions we'll get to a little later. One of the things that happens if you search for peptides online today, for instance, if you were to search on BPC 157, that's a mouthful to me, and you find an online marketplace, you scroll to the bottom of the page and they say things like, these peptides are being sold for research use and they're illegal for human use under U.S. law. Again, a minute or two, we don't need a lengthy legal treatise here, but just, who's at risk here? Where are these things coming from? Why are they being labeled this way? Let's start with that in a minute or so.
So the biggest risk is to the sellers selling that peptide. And because they're even though they say not for human use, they're marketing them for human use. Right. And the FDA has been looking specifically at this right now, and there are going to be thousands of letters going out to all of those people. If it hasn't started, it's going to be starting very soon, because they're going after this marketplace, and it's based on that these aren't, and the buyers aren't typically at risk. The physicians are at risk if they're involved with a patient where they recommend a peptide and the patient gets an online peptide. That doctor has no place to stand. That medical provider, I've been asked many times to help in malpractice cases. They have no place to stand. They're done. So you can't have any relationship with a patient that's doing anything online like that, because they're going to take your license. You're going to lose your license from the state board, and you're going to be lucky if you get it back. So the doctor is at severe risk. The seller, the big issue here is, the buyers, the quality is the danger. It's contamination, it's wrong dosing, it's mislabeled products. I mean, this has been looked at. It's actually the FDA is moving forward, anticipating. Let me give you this insight. This will help you with this question. The FDA is actually right now looking at better ways they can look at peptides, because they know something's going to be changing with peptides in the future as far as what they're going to have to do in the approval process. And they're looking at the immunogenicity, the immune reactions that come out of these peptides. It's not the peptide itself, it's how it's manufactured. And that's where the impurities come. And so
that's why I think we asked the question. I mean, the question just before this was about, are there things that are legal? And the answer to that is yes. The second question is, but there are some bad actors out there, and really depends upon who's involved, it sounds like.
Absolutely. And it's HIMSS can enter this space and do all the right things, just like most of the compounding pharmacies are doing all the right things. This doesn't happen no matter what anybody says, and no matter who. It's a false world out there, and there are a lot of problems that are happening that unfortunately I see out there that are happening with these online mislabeled peptides.
Yeah. All right. So I got two more questions before I pass it on to Jonathan. The first one is about patents, which I think you referred to earlier. So simple question. I think you answered it earlier. Are peptides patentable? It sounded like you were saying no, unless they tweak them in some way that is not already currently how they appear in the human body. Is that accurate?
Yeah. If it's around a formulation or a delivery system, or it's an analog, like GLP-1s
Sorry for jumping in and interrupting you, but I want to get this next question here, which is kind of think where you were just about to go. So do you have any thoughts on tirzepatide and semaglutide? Because what you were just saying made me think of it. In terms of their patents from a scientific and biological perspective, how is it that those two molecules are supposedly patentable?
Well, because they represent a natural GLP-1, but they've been engineered peptides. They're designed to have longer half-lives,
Right.
better receptor specificity. It's really good chemistry that's layered over the natural biology of a GLP-1.
Yeah, it's interesting though. So what you just said sounds like it's fairly clear that those are patents, they're
Yes.
allowed, and that they could potentially be held up in court, and yet we haven't seen them, Lilly and Novo in particular, being particularly aggressive about defending those patents, and some seem to think that they may in fact be vulnerable, which is interesting. So at least one case has alleged that it's not new art, that it's essentially prior art. We won't get into those legal specifics, but I wanted to ask you that question. If certainly you can add to that, but I'll just lead into my next question, and you can go back to the patent question if you want to answer something there. But the next question, which you can get to as soon as you have anything else to say, is really this: it's how did we get here? So we've got a history of big pharma. I mean, compounders, if we really want to get into history, we don't really have time for that, but they were around long before modern day pharmaceutical companies were. And yet you fast forward from, 100 years plus back to today, and the situation is quite different. And now we've got patents. We've got big pharma influencing the laws, creating much of the situation that we're in today. I suspect at least some of the pushback against some of the things, legally that we've been hearing about may have come from that direction. So if you go back to patents, if you want to add anything there, you can, but really just how did we get here? And I guess the follow-up question is, where do we go from here? But I'll leave that to Jonathan.
Well, I mean, I definitely think, it's all been, Big Pharma has directed this process. It's all about lobbyists. It's all about, a lot of these things have happened with peptides, like at the last minute when no one's been prepared. Like you had all these peptides that we had everything. We had no limitations pretty much on all the peptides, maybe it was a year and a half ago, before 2024, or maybe it was earlier, where everything was on the Schedule 1 list. And then overnight, some politicians added something, and then all of a sudden they were taken off and nobody knew why. And it's all, I mean, it's there.
What year was this, Dr. Seeds?
Gosh, I'm terrible with dates. It was like, I want to say that was about a year and a half ago, like 2024 or some point, maybe December, or before that. It's been within the last couple of years that something like that happened. They did some things years ago, maybe 5-6 years ago, where they about 5 years ago, that they changed the peptide, the number of amino acids, that where a biologic was before like 50 amino acids, they changed it down to 40. And that removed a few peptides from the list. So it's always been a struggle, I think, with what Big Pharma's agenda has been. And that, again, with a lot of these natural peptides, there's just there's no money there for them. But if they can take one of those natural peptides and they can alter it, like we talked about here, as far as in delivery system, or just changing, the ability of its half-life, or its ability to penetrate, or whatever, then they have the IP on that. And they don't want that natural peptide. They don't want you to see that, because that's something that's already working that you can utilize. Well, they can take that and make all these analogs and create all this IP and make, hundreds of millions of dollars on that process. So does that make sense as far as what I'm saying?
It does. I want to close with talking about what the future of this industry may look like. But before we turn to that question, I want to touch on something that you've said a couple of times, which is that the international landscape, in many ways, countries in Europe and in Asia are ahead of the United States.
Correct.
Can you give us a 101 of how the peptide landscape differs in Europe and Canada and Asia from the United States?
Well, there are definitely more clinical trials in Europe because they have more comfort with the thymosin. So those are the immune-related peptides and the neuropeptides. They're already doing that work. And they've been ahead of us for quite a while with that. In Canada, they're pretty much, the restrictions are pretty close to us. They have a little more flexibility in their research, but they're pretty much, they follow the US. In Asia, they've got peptides integrated into their elite clinics, Dubai, Singapore, Eastern and parts of Eastern Europe. But you're going to see this bigger surge, especially coming out of the Middle East, because they're ready to pivot and to get behind.
Any countries in particular that you have in mind in the Middle East?
I have.
Is it Saudi? Is it UAE? Is it Israel?
It's let's say it's Dubai and UAE.
Okay.
And I can tell you that is where they're going to change the face of all of this around the world. That's there's no doubt about that, because I'm involved in that. I'm working on that part. I'm working on that footprint in the Middle East, and it's incredible that and it's just not there. It's just not with that. It's a bigger space of all of improving health span and longevity, because that's where the future is. I mean, look what's happened here in the U.S. You probably recently saw how they've changed the laws in Montana. That was just recent here in the last week or two, where they've changed, the legislature changed the laws to make it a friendly place to do research and to have people come there to get their, they're trying to pull in people to do peptides and stem cell research, and you name it. You're starting to see states now take control of this.
So I do want to close with what may happen in the United States, and let's bring it closer to home for a moment and talk about HIMSS. HIMSS acquired, as most of our viewers will know, a peptide facility. I think it was in January or February of this year. They acquired a peptide facility in Northern California called CS Bio. I want you to look into your crystal ball, Dr. Seeds, and would like to hear what you think HIMSS will do with that facility. Specifically, what products might they launch? How will they use it? You could give us like a top 2 or 3 things they're likely to roll out.
Their main focus should be on GLP-1s. This explosion has just started. It isn't, we haven't seen anything yet. And the demand for these are going to be even more significant as more of this research which has been there, but now it's getting very driven in each silo of medicine, where you're starting to see this incredible pleiotropic aspect of these GLP-1s, meaning that they have true efficiencies in what they do to improve a cell, to not work on longevity, work on health span, make a real difference. And that's where the market is going to continue to explode as people start to see this dominance of GLP-1s. And so I think...
so HIMSS very well may use the peptide facility in California to produce GLP-1s. To my knowledge, they certainly were using the 503B facility in Ohio to produce GLP-1s, and they may have more recently shifted to the 503A in Arizona. But let's just think beyond GLP-1s for a moment. And I know we talked about what peptides are legal, and that should be on our radar earlier in the interview. But if you had to guess, what might HIMSS roll out? 2 or 3 peptides other than GLP-1s. What do you think it would be?
I think there's no doubt it's the GHKCU in the cosmetic world. That's a $1 billion industry. I mean, that's
what do those things do again?
GHKCU is a repair peptide that works through gene upregulation, downregulation of multiple genes specific to improving a cell's ability to adapt and to improve collagen, to improve elastin, to bring back integrity to the skin and soft tissue. It's an incredible repair peptide when it's injectable, but it's also as a topical, which is an allowable compounding peptide. It's an incredible. Let's, instead of using hyped words, it's a mechanistic peptide that has shown its validity in what it does to improve skin. And it's the hottest peptide in cosmetics. So you're going to see that combination with other ideas and combinations. And that's where people are making their, there are actually some FDA approved, I didn't mention, there are some other FDA approved Botox peptides that don't have the toxin aspect, but are peptides that are fragments of the Botox that do very good things for collagen, but don't have the toxic effects, which is where you need to be anyways, because Botox is ridiculous because you're creating problems for people later. That there are responsible ways in this to work in this world of the cosmetic world. And I'm more than positive Hims will go down that route.
Yeah, Hims does a little bit with cosmetics already, so that would be an interesting way to extend the work they do there. I was grinning ear to ear. I'm sure Patrick saw it. I'm sure you saw Dr. Seeds. I pulled up the Google Trends for GHK-CU, and I'll just tell the viewers. In 2023, we were at 4 or 5. This is a 0 to 100 scale. Google Trends does as a measure of popularity. 2023, January, we were at 5 out of 100. In July, early August, we just hit 100. It's like a 20x in 2 years in terms of search interest and popularity. And so we'll keep our eyes on that. Very interesting.
Well, here's another example. I mean, I can tell you without a doubt. I mean, the confidence I have in that is because I use it clinically and I see it. So it's very straightforward and simple for me to give you that perspective, because it really works and it really changes the landscape of anything that's out there, I think, as far as cosmetics. And I think there's lots of ways you can go with that. And so there's no doubt. I mean, VIP, vasoactive intestinal peptide, I think is another route that you're going to see as a injectable, as a nasal, that can be used for the brain, that can be used for the gut.
What was that one, Dr. Seeds?
Vasoactive intestinal peptide.
These guys need better names.
Well, yeah,
VIP. It's called VIP. How about that? Is that okay?
Okay, I got it. I have to say, when you're saying some of this, it sounds like Chinese, maybe that's a little off color, or another programming language that I'm not familiar with. Or
I'm sorry, it is a different language. It's a language of the cell, right?
It's even more intimidating than the vast majority of medical terms that I hear thrown around. And so we'll see if some of the peptide vendors come up with fun names like Ozempic or Mounjaro. But to be honest, these 3-number molecules are sort of frightening. And I imagine many people have the same reaction.
It's so we got a few more questions, although I can't help myself but note that I think one of the reasons why Ozempic is so popular is because of the name and because of the jingle, which is associated with a song from the 1970s.
You remember that? That was okay. So that's,
I am old enough to know what that song is.
So, it's magic. I could never get that out of my head. And when that was the first time, that was the first commercial that was ever done for a peptide.
I know. So we'll see what's coming in the future. You're going to need better names than the ones you just mentioned. I know that's a medical name.
Maybe Hims will create some names for some of these generic.
So a couple of broadly speaking, two more questions, although you have a little more time on these. The first one is just a point of clarity. I'll get to that one in a second. The second one is really about looking into the future. Jonathan kind of referenced it, but I want to get a better picture, and not just from the point of view of HIMSS, but in terms of the field. But let's start with the more mechanistic, short-term question, which, at least for me, was something I was a little confused by. Perhaps the audience caught it, but I didn't. And it's this. So you've mentioned a few different drugs, molecules, that HIMSS could go ahead and start putting out there in the very short term, cosmetics, some of the names you mentioned. Those things HIMSS apparently can do. And yet there are others apparently that could be out there in the pipeline that HIMSS cannot do today. I'm somewhat familiar with what the FDA process is in terms of branded pharmaceuticals. 3 different phases. You step up the studies at each step, so you have more smaller trials maybe at the beginning stage, and then you ramp up slowly towards stage 3, which is, potentially thousands, multi-site, all these kinds of things, much bigger studies. And then by that point, if everything is a go, you're good to go. But the process can take many, many years to go through all of those stages. So that's the process in very loose terms of what's involved in an FDA-approved drug. What is the process that some of these peptides that HIMSS cannot make today, but potentially could make in the future? What is that pathway that goes from it's not legal to it is legal?
It's the evidence-based clinical studies that can be
Clinical
done.
studies. Got it. Okay.
Yep.
All
And
right. You just answered my question. I guess I was just looking for some clarity there. So similar in some ways, perhaps less extensive compared to the 3 phases that I mentioned for an FDA-approved drug, but there's still evidence that's there. That's part of that process. Got it. Okay.
Yeah.
So my future-oriented question is this, and I think this is where, unless Jonathan's got some other questions, we may wrap things up. So you can take a little time to once again look into your crystal ball. So look into that crystal ball, look ahead to the next year or two, then look ahead to the next, say, 5 years from now, and then look even further, 10 years plus. What are we going to see in that crystal ball in terms of the future of peptides?
Let's start with the 2-year.
1 to 2 years. Very near term. We're not there yet, but it's not far away.
I think you're going to see an explosion. So I said the GLP-1 dominance is there. It's going to be an explosion in the demand for the compounded peptide, not the commercial peptide. That's
why is that?
Because of how you can dose it appropriately for the patient. You can't do that with the commercial dosing that come in those pens. You have to be able to alter these peptides to use them responsibly and to get the results you want, and to get like I said, the confidence in the patient, and to lower the recidivism rate of utilization of that peptide. You got to be able to tailor it, and you can't do it with the commercial peptide. You can't do it. You need the compounded peptide to where you can change the strength, concentration, and you can alter the amounts with the patient. And that's success. That's how we've done so well with it. And I guarantee you it's going to be an explosion in compounded demand. It's not going to be
quick follow-up question on that point, because it's super important, although I'm guessing that the audience caught this, but still. The current approval system, which takes years for an FDA-approved drug, as we've already described, is incredibly rigid and does not really allow the personalization that you just discussed. In some ways, it sounds like if there was an agreement, and I'm not sure there will be, that a more dynamic, personalized precision medicine is what we needed, with variability from one person to the next. The current FDA approval process just does not speak to that, to my knowledge. I may be wrong, but it doesn't seem to.
You're correct.
And so if that's the case, we're talking about a pretty revolutionary change in how medicine works and how medicines are approved, potentially. Not guaranteed, but certainly it's suggestive of that.
That's exactly, you're correct. And that's exactly what speaks to the senator's letter that he wrote to Secretary Kennedy. Exactly.
Senator Tuberville or Tuberville? How do I pronounce it, Jonathan?
Tuberville.
Tuberville.
Tommy
Okay.
Tuberville. And
all right. Going back to the crystal ball, we looked 1 or 2 years into the future. What's different 5 years from now and then 10 years plus?
It's definitely the mitochondrial. No doubt it's the mitochondrial targeted peptides and the neurocognitive peptides and the immune modulators. I mean, that's where it's going to go.
And when you say neurocognitive peptides that like make me smarter, raise my IQ, what do you mean by that?
To improve the environment. So if
I could use a few extra IQ points.
Me too.
if we're everything is so, one thing affects another. There are stressors in our lives, right? That as we age, as there are bacterial, viral stressors, there's stress from work, there's metabolic stresses in what you eat. There's all these influences that affect how a cell is metabolically efficient. And we know that there are many neurocognitive peptides that can support neurocognitive function. And we can make changes we can do things that are focused on improving that cell function and that signaling that controls the environment. And that's where everything goes wrong, is when you lose control of the environment. And if you know that and you can maintain that, well, and then and work on other aspects of controlling that excitability of the brain, like let's just say keep the air conditioner on, right? Keep it in a good place. You're going to enhance neurocognitive function, and we're doing that. So that's where it's going. There's no doubt. If we're already doing things for neurocognitive support, if we're already doing things to modulate the immune system, not to upregulate or downregulate, but to modulate the immune system, which is to let it work the way it's supposed to. And we've already proven that through the COVID era. Well, look out, because now as we get better world data that is going to be coming out now on all of these things, mm-hmm. that's my journey. In the next 5 years, that's where I'm going to be. I'm going to be pushing those groups forward, not just here in the US, but around the world, to lead this in a better place for evidence data in all these areas of the mitochondrial targeted, the neurocognitive, and the immune modulators. Watch out, because it's going to happen.
Jonathan, I'm going to turn it back to you, but we should get where do people find more about the work he's doing going forward?
Real quickly, did we want to ask about the 10 years plus
sure.
time horizon? Is there any difference in your view, Dr. Seeds, between what you said about the 5-year horizon and 10-year plus?
Yeah, absolutely. So, just think about this. You guys probably are more familiar. We're in this world now where once we have this real world data, this clinical data, mm-hmm. that's gold. That you can't, that's where we get into the AI driven personalization and the where you can do things with AI protocols precisely. If we get all this data, because that's my goal, is to mm-hmm. put all this data together in a deep learning model that's not no sci-fi bullshit. It's the real deal of.
I can't help but note that HIMSS has been hiring a lot of AI people lately.
Yeah, I can't help but note that HIMSS has literally senior machine learning engineer job postings out as of the last week or two.
Brilliant. They'll have to keep up with me then. So that's great. That's where it's going to be. It's putting, you got to have the data first though. And so, HIMSS is in a good position to collect data, but that's great. I need some competition. So I love.
Before I turn it back to Jonathan, I'm going to ask the question I was going to throw to him, but If someone wants to keep track of your work, which apparently you're doing a lot of, what is the best way to do it?
Oh boy, it's probably to follow. I'm not good about this, so about how you track me. It's probably through the SSRP, which is our educational platform, and that's what we use to educate our physicians around and certify them in utilizing these peptides and using them appropriately, and using GLP-1s and where we're headed with our research with other institutions and other areas, outside the U.S. So that's probably the best. The SSRP.
SSRP, does that stand for Seeds
Seed
Scientific?
Scientific Performance and Research, yeah.
Okay.
Or Research and Performance, yeah. Institute.
Yeah, thank you for asking that, Patrick. And I think we'll call it there. But Dr. Seeds, just wanted to say thank you again very much for your time and your expertise. And I'm very excited to see what HIMSS does with that peptide facility. I might travel to the UAE. I might do a lot of things. We'll see, or at least think about doing them. Anyway, I'll stop talking there. Dr. Seeds, thank you so much for being a part of HIMSS House.
Pleasure to be here, and thanks those are great questions. I think those are questions that hit everybody should be thinking about this, because this is going to change. It already is changing the world. We wouldn't be here if this wasn't happening already. So that's all I can say. And from the patient side of this, which I'm the advocate for, boy, it's a new world, and it's a privilege to be involved in that. And it's a special place where we can really start doing good things for the patient. It's arriving, and it's about time.